by the time we start, otherwise we are going to land up delaying the entire afternoon session. Can you give me the slides, please? Right. Good afternoon, everyone. My name is Kaushik Bhojani, and I hail from Mumbai. That is where I practice rheumatology, and I've been given the privilege of setting the tone for this very important topic. The WHO reports the incidence of osteoarthritis between 18 to 39% of the population. In India, the numbers are much higher, and about 45% of women above the age of 65 have symptomatic osteoarthritis. What I want to highlight here is the credit to the organizers about the fact that they've been chosen the speakers in such an opportune manner. So even the chairpersons, both of them hail from Gujarat, and I don't know whether you people are aware, but out of all the rheumatic diseases in this country, Gujarat has the highest incidence of osteoarthritis. Both chairpersons are from there. So it gives me great pleasure to introduce both the chairpersons for this session. May I invite Dr. Namisha Patel from Baroda and Dr. Shabir Chikani from Rajkot, both senior rheumatologists in the state, and both of them will be able to add their 2 bits to the beautiful lectures that we're about to hear. The first keynote presentation comes from Professor S.K. Das, who's going to talk on early osteoarthritis, and Dr. S.K. Das has been devoting his life to osteoarthritis. This is going to be followed by an international faculty who's done mammoth amount of work in terms of osteoarthritis from Australia, Dr. Benny Anthony. And then finally, we're going to have the question and answer session, followed by a little bit of brainstorming by Dr. Sahana Baliga, who's an upcoming rheumatologist. She's just finished her super specialty from Hinduja and heads back to Mangalore as a faculty. So over to the chairpersons, please. May I set the tone? May I invite Professor S.K. Das?
Yeah, Dr. Benny, can you join us, please? Dr. Sahana.
Is Dr. Sahana Baliga around?
Okay, no problem.
Could somebody just convey to her that her name is being called out? I think we shouldn't wait and yes, ma'am. Oh, I see. Okay, but will she be able to join in time for her session? Okay, thank you. May I invite Professor S.K. Das to give the first lecture, please? Thank you.
Thank you, Dr. Kaushik. I have a wonderful relation with Dr. Kaushik, and I think he's one of the best rheumatologists in the country. And then we have the chairpersons, Shabir Chikani, and I've become old now. And I've become so old that I forget names of which I remembered 5 minutes back. Now, Namisha is there, Namisha Patel. So I'm sure you will forgive me for forgetting names and forgetting some parts of the what lecture I'm going to give you today. So what I have to speak today is I've been assigned to speak on early osteoarthritis. Early osteoarthritis is something which is very important, and this importance of early arthritis stems from the fact that a lot of new drugs are likely to come in the next 10 to 15 years in the market, and once they come, it is supposed that the early osteoarthritis patients are going to greatly benefit in terms of holding the progression of disease and and also possibly in regression of some of the features of osteoarthritis, but we really don't know what will happen once these drugs come. So they are very innovative drugs which are likely to come. If we have to make a diagnosis of early osteoarthritis, or rather when we make a diagnosis of osteoarthritis, we make a diagnosis most commonly is symptomatic osteoarthritis. We can make a diagnosis of radiological osteoarthritis without clinical features based on X-rays only, but generally that would not be regarded as osteoarthritis. We will come to know why. We would very much like to diagnose clinical pre-radiological osteoarthritis so that we can then possibly start treating them at that stage so that radiological damage does not become apparent. And absolute wishful thinking would be if we could diagnose preclinical and pre-radiological osteoarthritis. That would be the best thing that we could do. There is no accepted definition so far of early osteoarthritis, but we can use clinical criteria, we can use radiological criteria on MRI, on compositional MRI, and by use of biological markers. All of them have been said to are said to provide early diagnosis, but I am doubtful whether they will be able to, except for the clinical. Currently, osteoarthritis is not considered as osteoarthritis unless there is a pain in the joint. You may have all radiological features, but yet if there is no pain in the joint, it is not counted as osteoarthritis because the criteria of 1986 say so. Pain is currently considered as essential for the diagnosis of osteoarthritis. Other features are secondary features. So we can have a clinical and laboratory diagnosis, we can have a clinical and radiographic diagnosis, and just a pure clinical diagnosis as well. The clinical and radiographic diagnosis has a 91% specificity, 91% sensitivity and 86% specificity, making it the most suitable and ideal criteria so far. This is the most commonly used definition of osteoarthritis, and this is based on on the Kellgren and Lawrence scoring system, a grading system for osteoarthritis. The ORSI has come out with a very good atlas, but that is not being used so commonly. The grading is, you can see the various grades, and you can see this is grade 0 or normal. This is a slight decrease in the space. Here is again a little bit of spiking, and maybe there may be some, this is an osteophyte here which you can see, grade 2. So presence of osteophytes and other things makes it grade 2. Grade 3 is when there is quite a significant narrowing plus more bigger osteophytes, and grade 4 is when there is no space left. We can also look at osteoarthritis in MRI, and we have some wonderful MRI images here. You can see is osteophytes. I think you can follow the arrow that I am showing. Osteophytes. You can have is damage to the menisci, damage to the menisci. You see a beautiful presentation of the cartilage which can be seen in certain sequences of MRI, and I'll show you a slide, some more of MRI images. Some effusion, damage to the meniscus, damage to the bone. This is bone marrow lesions which can be present, damage to the meniscus. So meniscal damage comes out to be a very important part of the whole story, and this is again is osteophyte, meniscal damage, again meniscal damage, and here you see is a beautiful description of how the cartilage damage can look on an MRI. You see that the cartilage has been denuded to a large extent. You can also look for synovitis. clear-cut synovitis distinct from synovial effusion. This shows synovial effusion plus synovitis, and this technique here would show that yes, this is synovitis. The synovium is showing an increase, and whereas the water here, the synovial effusion, has been suppressed. So you can, there are a number of ways. It means MRI is very complex. It's not very simple for most of the rheumatologists, including myself, to understand. But yes, we can understand some of it, and what we see is that yes, this synovial effusion can be removed, and we can see the synovitis directly in MRI. Ultrasound can also be used. It permits a visualization of the articular and periarticular tissues. Initially, we used to think that since the ultrasound waves do not pass through the bone, it would be a worthless entity, but we have seen that yes, it's a pretty good entity, pretty good method to see. As compared to MRI, it is safer, it is inexpensive, and less time consuming. It can detect hyaline cartilage changes like blurring of the edges, which become irregular and lose normal sharpness. It can also detect synovial hypertrophy, joint effusion, increased vascularity. The increased vascularity is generally seen using the power Doppler, and if you are using power Doppler, you can use it, and I'm sure more people should start using power Doppler to examine joints. The ultrasound of the cartilage may hence be a useful tool to detect early osteoarthritis. There are a number of biomarkers, and many people have said that biomarkers would be good to assess how much of damage is going on in the cartilage and whether it would be useful or not. And there are a number of them. Most commonly used are urinary CTX, terminal telopeptide of collagen 2, because collagen 2 is the most common variety of collagen present in the cartilage, and the other that is present as a degradation marker is serum comp, which is very commonly used. So these are the two ones, the rest are not that frequently used. However, bone markers have their own story. For cartilage, the increased products, increase in the products, or these products, degradation products, indicates that cartilage is being damaged. But how much damage is occurring depends upon how much is the cartilage. Knee has a small amount of cartilage, the whole body has a large amount of cartilage. If cartilage degeneration is going elsewhere, it complicates the matter. It does not reflect only the knee joint. Similarly, if the cartilage has been damaged to a very large extent, however fast the cartilage may be damaging, it would not be high levels, it would be still low levels. So it is a very complex method of looking at degeneration of the cartilage, but yes, some people are very adamant, or they think that yes, this is a very important method of looking at it. It is complex. To understand biomarkers is complex. Then we looked at the MRIs. Early diagnosis of MRI has been recommended by one person as diagnostic of osteoarthritis, and they said osteophytes, cartilage loss, bone marrow lesion, and meniscal tear. If 2 out of these 4 are present, you have is osteoarthritis. But there is no clinical here. There is no pain here. You could have, without pain, you could have osteoarthritis by this MRI definition of osteoarthritis. It's a pretty old slide. We have also some markers which suggest that pre-radiographic MRI changes predict development of clinical osteoarthritis later on in patients who have infrequent knee pain. And fluctuations in knee pain occur in pre-radiographic osteoarthritis with changes in size of the bone marrow lesions. If the bone marrow lesion increases, pain increases. If bone marrow lesion decreases, the pain decreases. So this has also been studied and said to be present. So early pointers to pre-radiographic osteoarthritis and preclinical osteoarthritis are that some MRI changes predict development of clinical osteoarthritis in patients with infrequent knee pain. So ultimately it seems that infrequent knee pain is coming out to be an important method of looking at early osteoarthritis. In one study, they looked at patients who did not have osteoarthritis on X-rays. There was no radiographic osteoarthritis, and they did an MRI. And they found there was no difference between them and those who had radiographic evidences of osteoarthritis. The findings were exactly similar. So the authors, a very well-known figure, Dr. Gurmazi, he concluded that the MRI changes are just by the way, they are not related to osteoarthritis. So people are not ready to accept that MRI changes are really reflecting osteoarthritis. So this kind of a controversy is still there, it has not been removed. We did one study in which we did screened 1328 persons in population for knee crepitus. And amongst those patients who had knee crepitus, we did an X-ray, and if the X-rays showed osteophytes, we went ahead and did MRI. So we had two groups of patients, one with pain and the other without pain. The number of patients with pain was 61 and without pain was 48. And in this we had grade 1, with pain there was 0 in grade 1, but we had 10 patients or 20% patients in without pain group we had in grade 1. In grade 2 similarly, grade 1 and grade 2 we had more patients as compared to what we had in the pain group. And this was significantly different from each other, suggesting that these patients were patients who were early patients of osteoarthritis. And if you look at their age group also, they were of lesser age as compared to these patients with pain who were of a greater age. So basically we say that these are patients, we did an MRI in early osteoarthritis versus who had later osteoarthritis. So we had these significant associations with pain: osteophytes, cartilage damage, lateral meniscus damage, joint effusion and synovitis, and synovitis alone. We had significant difference in these two groups, suggesting that yes, synovitis is an important feature in patients with early osteoarthritis. We had some patients with bone marrow abnormality, but it did not come to a level of significance, but otherwise this also seems to would have been significant. So somebody did a MRI and said that this is osteoarthritis and gave chondroitin sulfate, and at the end of the year repeated it and saw what happens to it. And he found that the cartilage loss was decrease in cartilage loss as early as 6 months. Such studies need to be done again and again to be able to predict what will happen in this kind of a scenario. So, but even MRI is not useful for mass scale clinical work and can not be used for it can be used for research and occasional case work, but not for epidemiological studies. So that's a drawback of MRI. Though MRI is a good modality to assess, but it's not very good. It will not be a very useful technique ultimately. Quantitative compositional MRI gives us even earlier images than that. And depending upon what technique that you have used, there are a number of them, for example, sodium signal mapping and all that, and you find that yes, there are changes in the cartilage that can be demonstrated early, showing that there is a decrease in glycosaminoglycans in the cartilage tissue in these patients. But this MRI, again, MRI, compositional MRI, cannot be used for epidemiological or routine work, because basically the machines that are used for it are high-end machines, and you cannot use them on a large scale. You cannot carry them out into the field to do it. You will have to call patients to your place. So even for clinical work, they are being used for, some of these techniques are being used for cancer management, but nobody has started using them on a routine basis for osteoarthritis work. Lewton gave a definition of early osteoarthritis in which he said that arthroscopy could be used. Based on this, he said osteoarthritis can be diagnosed early if you do an arthroscopy. But again, this arthroscopy is not a practical tool for looking for early osteoarthritis to start managing patients. Hence, we are left with clinical to diagnose early osteoarthritis. We cannot diagnose early osteoarthritis by any other method except on a mass scale, except by clinical only. Using the data from osteoarthritis initiative incidence, the incidence of pain on stairs, whether going upstairs or coming downstairs, can be used to identify those who are likely to develop osteoarthritis. So this is an important criteria. The second is infrequent pain. There is pain sometimes there is no pain. Pain for 10 days in the last 6 months twice can be used, and this is something which may be there. So that can also be used for osteoarthritis. So to make a clinical definition of osteoarthritis, ORC has formed a task force to define early osteoarthritis. This task force is headed by Lomander. The task force is tasked to make a clinical algorithm without taking the help of investigations to indicate early osteoarthritis. So this is what we want to do. At 40 years of age, everyone cannot be investigated for early osteoarthritis. We accept the criteria brought out forward by this group of investigations. Investigators will provide pointers to persons who need to be investigated. My speculation is that they will introduce a point-wise system. Everywhere there is a point-wise system. You may want to make a diagnosis of rheumatoid, point-wise system. If you want to make a diagnosis of gout, point-wise system. So they'll also come out with the point-wise system. And they have these various things to consider, and maybe intermittent pain for last 10 days each year, twice a year. Pain on coming down or climbing stairs would be given for 4 points. Joint line tenderness may be given 1 point. Crepitus on knee joint may be given 2 points, and some things like that they may give points, which may be added up to give a score of, well, if this is the score, you have early osteoarthritis. If this is not the score, you don't have osteoarthritis. I would refer you to two articles. One is Nature Rheumatology, 2019 article establishing outcome of measures in early knee osteoarthritis. Article which has been by Lomander's group and is possibly what is the starting point of this making a criteria. And the second is an article which I wanted to tell you, article which appeared in 2018, which could also be very well used for studying more about osteoarthritis. Thank you very much for a patient hearing, except for the computer was not very interested in letting me finish for a minute's time. Thank you very much.
Invite Dr. Anthony to speak, give his talk.
Thank you, everyone. First of all, I would like to thank the organizers for giving me a chance to present over here. So today I'll be talking about the predictors of treatment response. Yes, it's up. So I am from the University of Tasmania. So I'll start with defining what is the treatment response in OA. So you must have been already familiar with some of these concepts like the minimum clinically important difference, which is a difference that represents a change that would be considered meaningful and worthwhile by the patient, such as he or she would be repeating the treatment again. So a similar concept is called the minimum clinically important improvement, which is the same. It is the improvement that is considered meaningful by the patient. So whereas the patient acceptable symptom state is a slightly different one, it is actually a threshold representing pain which a patient would accept for the remainder of his life. For example, current treatments might relieve the patient pain according to the minimum clinically important difference, but they may still have pain, higher level of pain. So as similar to the ACR 20 and ACR 50 criteria, we can define improvement in pain, 50% improvement in pain or symptoms, and 20% improvement in pain symptoms in osteoarthritis as well. And the OCA and OMERACT have come up with a definition of responders, which takes into account pain and function as well. So briefly, what it means is like, if you have a high improvement in pain or function, that means more than 50%, with an absolute change of 20. Absolute change means the follow-up minus baseline. So you can be a responder even if you don't qualify 50% of the improvement in pain. If you qualify 2 of the following criteria, which includes 20%, which is a moderate amount of improvement in pain, function, or patient's global assessment. I gave a talk on this one yesterday already and on how to assess and all those things. I'm not going to the details of all those things. So why do we need to measure treatment response in OA? So we know that continuous measures are really fantastic to, and statistically more powerful to detect a difference between the treatment and placebo, or difference between 2 different types of treatments. But we know that it's very hard to convey the results to the patients. So for example, the Kurkova trial, which was a highly bioavailable turmeric extract for knee osteoarthritis clinical trial, which we conducted in our center, we only needed 70 participants to detect a minimum clinically important difference of 18 millimeter. And this already took into account the 20% dropout as well, and we had nearly 80% power. And another clinical trial, which is currently ongoing in our center, which is the stem cells for knee osteoarthritis trial, or SCULPTURE trial, we powered it for patient acceptable symptom state. So we know that nearly 35% of the people in the placebo group respond to the treatment, and with the pilot data shows that nearly 48% in the stem cell injection group respond to the treatment. And if you use it for power calculation, we nearly need 440 participants for detecting a meaningful change. That is a 16% increase in the patient acceptable symptom stage threshold. So that's one of the drawbacks of using dichotomy variable like treatment response as an outcome in osteoarthritis trials. As I mentioned, the Kurkova trial, which was a highly bioavailable extract of turmeric, and this was a smaller trial on 70 patients, followed up for 12 weeks, just 3-month trial. And on 70 patients, we published in Annals, and then what we found here was a 9.11 millimeter out of a 100 millimeter scale difference between the treatment and placebo group, which is actually lower than the minimum clinically important difference, but statistically significant. So how do you convey this to the patient? So you'll have to say that, if you take this drug medication, you might have a 9.11 millimeter difference expected compared to the placebo. So it's very hard. That's why we do OMERACT. What I'm saying is that there's a strong placebo effect in osteoarthritis. And this was a systematic review from the UK, and they have clearly mentioned it. You can see the overall treatment effect of all the treatments of osteoarthritis, and out of that, 75% is contributed by the placebo alone. So 75% of any effect of any treatment in osteoarthritis is actually contributed by the placebo effect. And here you can see in the top, NSAIDs have got a very strong, topical NSAIDs have a strong effect. Out of that, 85% is actually contributed by the placebo. And most important here is to look at the intraarticular hyaluronic acid injection, which is not recommended in any guidelines. And here you can see that they've got a total effect is very strong. That's why every patient you come to the clinic, they get a response to the treatment, even if they put the intraarticular hyaluronic acid. But out of that, 82% is actually placebo effect. And what you need to here look at that is the intraarticular corticosteroids. The total effect of the treatment is actually even lower than the intraarticular hyaluronic acid injections. But you need to see that it was only 47% of the intra-articular corticosteroid injections were contributed by the placebo effect. Probably because, when you're going to inject the patient, you're telling that I'm going to inject steroids. The word steroid itself comes up with scary, and then they're going to get, they think that it's not going to be that much effect. But on the same time, when you're injecting hyaluronic acid, you might be telling them, I'm going to inject some lubricant into your joint. So that's more attractive to the patient, and you get a stronger effect. For a patient, it doesn't matter. Only the total effect that matters. So I would suggest you to keep this slide in mind and make use of it in your clinical practice, because a patient, all it matters is how he get better. So when we look at the predictors of placebo response, generally the same systematic review found that higher the effect size of the treatment, higher the placebo response. And also that higher the baseline pain, higher the placebo response. And more the invasive the treatment is, higher the placebo response. For example, invasive treatments such as acupuncture, intra-articular injections or intramuscular injections, and intravenous and surgical therapy seems to have a higher placebo response. And we are currently conducting a clinical trial comparing yoga with the standard exercise. So thereby we hope to eliminate the contextual effects or placebo effect, because both are active interventions. And here we have specifically mentioned a priori hypothesis that the central sensitization phenotype of participants who will be measured using a pain detect score more than 12 will have a higher response to treatment in the yoga group, because the yoga therapy only in way it differs from the standard therapies. There is got more central components, which include the meditation, which might be beneficial for the central sensitization. So in an exercise trial which was conducted, which compared physical therapy for hip osteoarthritis, what they found that if you have unilateral hip pain, if you're lower in age, if you've got a higher knee pain, that is more than 6 out of 10, and if you have better fit at baseline, or if you've got lower duration of symptoms, that means less than 1 year, then you're highly likely to be responding to the physical therapy treatment than if you don't have these things. So next I'm going to the intra-articular steroid injection studies. Here the OA Trial Bank is an initiative from OCS, Professor Das told. It's actually an initiative where they will combine all the clinical trials published in the area. For example, and this was a OA Trial Bank initiative for intra-articular steroids, so they combined all the clinical trials published in that area and requested the original data for that, and then they looked at the individual patient level meta-analysis, and then they found that there is an increase in the short-term efficacy, that means up to 4 weeks, from intra-articular steroid injections in patients who has got more severe pain, that means more than 70 out of 100, that means 7 out of 10 scale. If you've got a severe high pain at baseline, you're highly likely to respond to the steroid injections. However, as none of the no effect modification signs were of inflammation either by physical examination or by imaging, such as the ultrasound wasn't there. I suspect that that was because, although it was an individual pooled up data, I think they weren't powered enough to detect a subgroup analysis to detect whether the signs of inflammation had a higher response to treatment of intra-articular steroids. And the same group actually, OA Trial Bank is actually right now looking at the predictors of placebo response in intra-articular injection trials as well. As I mentioned, I need to talk about the placebo effect of the injections. That means most often in the controlled trials, it's mostly the normal saline that's been injected. And you can see that there is a strong placebo response for injections. Here at the center, you see the minimum clinically important difference. In all domains of pain, stiffness, and function, there is a strong effect, especially when you look at 1 month, the short-term effect of intra-articular placebo injections on osteoarthritis patients. How about biomarker as a predictor of treatment response? So this is the turmeric trial which we conducted. We also did the contrast-enhanced MRI in these participants, and we also assessed the serum biomarkers for inflammatory markers such as the IL-6, CRP, and TNF-alpha, also a cartilage marker for MMP3. And when we looked at whether these 5 factors predicted treatment response in over 3 months in the in Kurkova trial participants, we found that the higher baseline inflammatory markers such as the IL-6, CRP, and TNF-alpha were associated with a significant response to treatment. I mean, if you have a higher inflammation pain, you are highly likely to be responding to an anti-inflammatory therapy. What about NSAIDs? What about the predictors of NSAIDs? There are some evidence to say that higher serum higher serum lysophosphochlorine to phosphatidylcholine ratio, which suggests again the inflammation is actually seems to respond better to treatment for NSAIDs. Similarly, there is a presence of central pain sensitization. That means in people with central sensitization, there was a poor response to NSAIDs, and there is also some evidence to suggest that patients using NSAIDs with the baseline pain intensity of more than 40, that means if you have got a moderate amount of pain, you seems to highly likely to respond to NSAIDs rather than you treat it to everyone. So I would like to speak a little bit about the NF1 trial, which is, I personally think that's the best design if you want looking for to identify treatment response for osteoarthritis. So NF1 clinical trial is technically actually a crossover trial. So, but you're using 3 different series. So every time the participant come into, so it's an individual bevel, so you can do this at in your clinic. That's why I'm showing it here. Everyone can do it. So it's mostly done it to compare 2 different interventions rather than placebo. And everyone comes into the trial at the baseline. They get randomized. They might get an intervention or a control at the start. Then you have a washout period. Then you get the second treatment or whatever control at the second time. And then they go for a washout again. And then you look at the response to the treatment over in a questionnaire, and then you quantify yes, no, like that. And then you have again a washout, and then again you randomize, and then you have an intervention group here, then a control group again. So based on the intervention, that means if you're taking A, B, you can have A, B, or A, B, A, like that. So you get 3 cycles, or even you can have more, but there's no point in having more. That's what the evidence says. So you're increasing the number of power, increasing the power using the number of rotations as well. So you can do this type of individual trials in your clinic as well. So NF1 trial that focus exclusive on optimal intervention for a single patient are compatible with the ultimate endpoint of clinical practice. So I would strongly suggest you guys to use it in your clinical practice if you are confused with some medication, so one is better than the other, and if you want some evidence, you can do it yourself in your clinical practice. So this is an example, which I'm not sure if I have time. Yeah. So this is an example from UK where they've compared 2 topical NSAIDs, topical NSAIDs compared with capsaicin, and what they found is that there was no difference between the treatment groups in terms of the continuous measure of pain. But when they looked at the responders, they found that nearly 59% of the people in the capsaicin group responded, whereas only like 20% of the people in the topical NSAID group responded. So actually, when you look at this kind of smaller less popular NF1 clinical trials, it's the best method to identify which one treatment really suits in your clinical practice. So, and in terms of sample size, I'm not going into the details, if you really want, in order to detect a minimum clinically important difference of 0.5 standard deviation between treatments, if there was a way 66 participants were required in a traditional parallel comparison trial, 33 in a crossover trial, 11 in a series of NF1 trials. So that shows the attraction of why you need to use an NF1 trial in your clinical practice, which doesn't require a lot of time or amount or money as well. So I would like to stop there by thanking my funding bodies, and thank you to the organizers again.
So it'll be Dr. Sahana to take on the next presentation, please.
Good afternoon, everyone. I thank the organizers for giving me an opportunity to speak today on this topic on osteoarthritis. So basically, to start with, we'll just touch upon the inflammation part of it. So what you see here is whenever there's a schematic representation of chronic inflammation as a mediator of osteoarthritis. So following a joint trauma or overuse, there's tissue damage which would activate, which can produce damage associated molecular, which can stimulate the damage associated molecular patterns called as DAM, which include cartilage components or ECM breakdown products. And this would activate the synovial macrophages, or also it could activate the fibroblasts like synovites, producing inflammatory cytokines. So there is fat pad derived cytokines as well around the knee joint, which would also contribute to the inflammatory pathology. This would lead to activation of metalloproteinases, hydrolytic enzymes, leading to collagen breakdown and over time cartilage loss. So coming to the pathophysiology, so the end of what happens is, what you see is the changes in the articular cartilage. There is loss of normal phenotype, thinning of the articular cartilage, and at the level of subchondral bone, there would be subchondral bone sclerosis, and there's thickening of the subchondral plate, later over time leading to bone attrition. So there are many studies, and you've heard our speakers speak on inflammation in OA, and they also have shown that there's increased mononuclear cell infiltration and inflammatory mediators more and early compared to late disease. And also there are studies done by Iracon who have shown that arthroscopies on knees on patients with pre-radiographic OA also revealed clear association between synovitis and future development of cartilage loss. So coming to the drugs that have been treated for targeting inflammation in osteoarthritis, these are the commonly used drugs. So I'll touch upon some important drugs and some landmark trials on that in the coming slides. So coming to NSAIDs. So this is a study that compared the long-term NSAID treatment comparing two drugs, the aceclofenac and celecoxib. And what they found that aceclofenac and celecoxib both reduced pain to some extent, but in addition, celecoxib also reduced macrophage infiltration, interleukin-1 beta levels and TNF-alpha levels. And there was another study to find the association of pharmacological treatment with long-term pain control in patients with knee OA. It was a meta-analysis, and they found that glucosamine sulfate showed improvement in physical function and joint structure, whereas celecoxib showed a mild improvement in pain, but not much improvement with the physical function. However, compared to other NSAIDs, celecoxib had better long-term gastrointestinal tolerability as well as cardiovascular profile. So coming to the next drug, which is methotrexate, which we commonly use in RA. So there was a systematic review of methotrexate use in OA, where they found that when it was used in erosive hand OA and CPPD-induced, CPPD osteoarthritis, there was significant decrease in pain after 2 months of treatment, whereas not much improvement in patients with, with knee OA, especially when it was used in moderate to severe grade osteoarthritis. And there was another study called as PROMOTE study, which was a randomized controlled pragmatic trial who included 155 patients with KL grading 3 to 4. And they found that at 6 months there was improvement in stiffness and physical function according to WOMAC grading, but not pain. And also these benefits were reduced by 12 months. Coming to the next drug, hydroxychloroquine. So this was used in knee osteoarthritis, erosive hand OA, and they found positive superiority over placebo. But there's a study that's done by Savio et al., which did not show much effect with hydroxychloroquine. And there was an RCT that came up using hydroxychloroquine in studying the effectiveness in OA. And even this did not show much relief compared to placebo in patients with moderate to severe hand OA. So next commonly used drug is prednisolone. So this is used in many ways, like intramuscular, oral, and intraarticular. So coming to intramuscular methylprednisolone OA hand, what they found was in 67% of the patients, there were 20% reduction in pain at 4 weeks, but there was not much reduction in ultrasound detected synovial hypertrophy or power Doppler signal. And there was a 6-week treatment with 10 milligram of prednisolone in hand OA, which is the HOPE trial. This was a double-blind RCT, which also showed that there was significant reduction in pain compared to placebo. Hence, you can use it in a flare of hand OA. Coming to the intra-articular triamcinolone versus saline on knee cartilage volume, they found that 2 years of intra-articular steroid significantly reduced cartilage volume loss, and there was no significant difference in knee pain. Next drug is interleukin-1 inhibitors in the treatment of OA, and here anakinra was used, and they found that it was more useful in large joints compared to small joint OA, and it could be used as an alternative to intra-articular steroids. Intra-articular injection of anakinra was also studied in OA patients, especially in knee OA, and this was again an RCT, a double-blind RCT. But here they compared placebo with 50 and 150 milligram of anakinra, but this again did not show much improvement in OA symptoms compared with placebo. There was another study where this is a new drug, it's a phase 2 trial, lutikizumab, which is dual, it's interleukin-1 alpha and beta immunoglobulin, it's a monoclonal antibody against this. Even this did not show much improvement in OA patients, even in different doses, 2500 or 200. Coming to the next drug, which is commonly used, most of our, some of our rheumatologists do use this for knee osteoarthritis. There was a Cochrane review this in ortho evidence, and this also showed that colchicine could be safe, but it is not effective in reducing pain and improving function in knee OA. And there's another study that's come called CORD trial. This is a double-blind, randomized placebo-controlled trial. 16 weeks with colchicine, 0.5 milligram BD versus placebo was studied. So compared to placebo, it was, placebo showed much improvement in WOMAC scores compared to colchicine. But however, it was not statistically significant. And hence the study concluded that use of low-dose colchicine was not effective in reducing short-term symptoms. So can interleukin-1 inhibitors have a role in osteoarthritis? Maybe, yes, in coexisting crystal arthropathy, in CPP-induced or BCP-induced crystal arthritis, especially in patients with knee OA, 20 to 25% of the patients can have CPP-induced arthritis, and also in small joint OA. So this could have some role in these patients. The another drug is anti-TNF, adalimumab, especially in OA, has been studied in erosive hand OA, and also, but that did not show much improvement with pain, but yes, it did reduce the number of swollen joints. Coming to RCT in erosive hand OA, even that failed to detect any clinical or structural difference. But there's an open label study for 12 weeks that was done on adalimumab in OA patients. It showed a positive result in 20 patients with inflammatory refractory knee with knee effusion. So this was an abstract that was published in ACR, that was present in ACR, where intra-articular infliximab could improve the total WOMAC score and cellularity. So they found that in 6 of the 16 subjects with high levels of synovial cellularity at baseline, 4 of them had greatest improvement. So anti-TNF could offer a promising therapy. And again, etanercept was used in 90 patients with erosive inflammatory hand OA, but here the primary outcome was not met. So finally, putting all this together, maybe despite the clear role of inflammation in OA, the recent trials on these drugs to inhibit, especially TNF-alpha and interleukin-1 beta, proved disappointing. No studies have targeted very early OA where inflammatory intervention might be most effective and could be promising. And early recognition of risk factors, as Gupta sir mentioned, would be, and a highly sensitive imaging could hold a promise in identifying at-risk population. So with this, I would like to end my talk, and over to Chikani sir to give his words of wisdom on this. Thank you so much.
Thank you, Sana. And my co-chair, Dr. Shabir Chikani, will give the final thoughts on this, and then we can take the questions.
Where is my... Yes, only.
It's down, just down.
So they have closed.
No, I thought you can stand up. It goes down.
Right, so we are short of time, so I'll bet like Surya Kumar Yadav, and I'll finish off in maybe five sentences.
It's not moving.
I think the slides, can you help us?
Smooth the next one.
All right.
I go.
So osteoarthritis is an inflammatory arthritis, that is for sure. In 2013 review, it was convincingly argued, it listed the evidence at that time, that it is osteoarthritis and not osteoarthrosis. Now, if most of the inflammation of osteoarthritis is local, but there are systemic effects also, and the evidence is building up. The question is that if osteoarthritis is inflammatory, then why there are not many drugs available like in other prototype inflammatory arthritis like rheumatoid arthritis? There are 3 important reasons. One is that the inflammation of osteoarthritis is driven by innate immunity, as compared to adaptive immunity. And we don't understand the innate immunity as well. And that is why we don't have so many molecules that target the innate immunity. Macrophages play a very important role in pathophysiology of inflammation of osteoarthritis. The second thing is that the severity of inflammation fluctuates over a period of natural history, and the natural history is very long, and it may not be wise to continuously immunosuppress patients. The risk-benefit ratio may not favor the immunosuppression. And third, now the slides have come. So this is the article I was talking about. It was published in 2013. Again, the slides have stuck. It's not moving. All right. Right. So the inflammation of osteoarthritis is also patchy. It is not like involving whole joint. It is not as exuberant as rheumatoid arthritis, and that is why it does not always correlate with symptoms. So treating osteoarthritis with immunomodulators, immunosuppressants may not give symptomatic benefits to the patients always. So what do I do in my practice? I don't treat osteoarthritis always as an inflammatory arthritis. There is a large body of work that has gone in the last decade, and possibly osteoarthritis is going in the direction of spondyloarthritis, where we are seeing subtypes of phenotypes of osteoarthritis, which are driven by underlying endotypes, that is the pathophysiological processes, and we have to understand these processes, and we have to choose our patient, the patients who have a typical inflammatory arthritis symptoms, objective signs, and evidence. Those patients only should be treated as inflammatory arthritis, and not all patients of osteoarthritis. Thank you.
Thank you, Shabir. We are, as usual, running short of time. We can take 3 questions from the audience. Quick ones, short ones, and even if it's a comment, it has to be a short sentence. Any questions? Yeah. No questions?
Here, ma'am. Lalit Dugal from Delhi. One quick comment. Not much take on osteoarthritis of the hands, which is a very important entity now. And secondly, role of PRP and stem cell therapy. Now, stem cell is coming in a very big way in India, at least, to ward off or even prevent, TKRs and surgical procedures.
Yes, sir. Your point is rightly made. We usually talk about knee osteoarthritis, and we always forget about hand osteoarthritis. The inflammation of hand osteoarthritis is different than what is going on in the knee osteoarthritis, and that is why there are studies which shows the difference in the response to various therapies. And for the stem cell, there is a whole session going on parallel in the other hall.
PRP.
Yeah.
There have been lots of studies for PRP, and generally it has been seen that when you take a look at isolated studies, it's a wonderful drug. But when you do a double-blind trials of these PRPs or stem cells, they never show a very good response. They are just Me Too products. The next thing which is there is that never has been any disease modification been shown by PRP or by stem cells so far in good trials.
Your mic is not on, please.
So how do we make out whether it's an inflammatory or osteoarthritis, and if it is inflammatory, would the CDMRDs work in a clinical practice?
Could you repeat it?
How do we make out it's an inflammatory phenotype osteoarthritis?
Is it inflammatory? Phenotype of osteoarthritis.
And if it is an inflammatory,
I'll draw the session to a close, and I would like to invite Air Vice Marshal Shankar Subramaniam to kindly take over for the next one. Thank you very much.